All right, good evening, everyone, and thank you so much for joining us tonight for our main event. We are going to be discussing the topic of covering glaucoma from A to Z, glaucoma grand rounds, with Dr. Justin Schweitzer and John Berdahl. I'll be your host tonight. My name is Dr. Arielle Ferenzi. So it's my pleasure to introduce Dr. Justin Schweitzer. We all know and love him. We've seen him. I'm sure you guys have seen him multiple times speak either on WooU or at local optometry or ophthalmology meetings, and you can also catch him at AOA this week as well. So he specializes in advanced glaucoma, refractive surgical clinical care, and anterior segment pathology at Vance Thompson Vision. He is also the chief medical editor for Modern Optometry and has contributed to many book chapters, journal articles, and case studies in peer-reviewed journals. And yeah, we've had the opportunity to hear from you so many times through you. We just can't get enough of your awesome lectures. So thank you again for joining us tonight.
Thanks for having me.
And then here are his financial disclosures, all of which have been mitigated. And then our other lecturer tonight that we're honored to have is Dr. Berdahl. He's a board certified ophthalmologist and LASIK, cataract, cornea, and glaucoma surgeon. In addition to being part of the small group of US surgeons that are fellowship trained in cornea, glaucoma, and refractive surgery, he's also an entrepreneur and co-invented the MKO melt, created astigmatismfix.com, founded Equinox, and co-founded expertopinion.md. So I don't know when you guys sleep, but we're sure lucky to have you, and we look forward to hearing from you both. And here are his financial disclosures.
Thanks a bunch.
Cool. All right. All of them have been mitigated, and I'll let you guys take it from here. Thank you.
Well, thanks so much for the kind introduction. Really appreciate it. And I always love being back on WooU. So thanks for having us. And it's really a special night for me to be able to do this with my partner in crime at Vance Thompson Vision, someone that I've had the opportunity to work with now for 12, 13 years. It's growing. I've learned so much from John in the glaucoma world. Did my fellowship with him, learned from him. And John, really looking forward to spending the next 50 minutes with you talking about a bunch of glaucoma cases and how we manage these things together.
Yeah, Justin, man, I'm just so impressed and proud of what you've done and how you helped lead glaucoma across the optometric space and the things that we do every day together for the benefit of our patients. You're a great friend and a great colleague, but I just love working every day with you.
And we want to thank everyone else too for joining us tonight. I know it's never easy to take time away from family, friends, significant others to do things like this. So I just want to thank everyone that's joining us this evening to spend some time with us. And please ask questions, throw them in the chat box. We'll make sure we leave a little time at the end. So John, I wanted to kick it off just kind of with this overarching puzzle of glaucoma. I think it's always important to get in the right mindset when we start thinking about cases, because it's very easy to get caught up just in one of the puzzle pieces, particularly intraocular pressure. We look at IOP and we say, boy, that's a high intraocular pressure. That patient has to have glaucoma. And that's just not true. It's really important that we look at all the different puzzle pieces to use all the different technology. And I kind of listed all those on the left side. And would you agree that all of them are important in getting that center puzzle piece of glaucoma?
Yeah, look, and there's probably things on here that aren't on here that are important. Maybe things like CSF pressure, what's the compliance of the lamina cribrosa, what's ocular perfusion pressure, da 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 da. We could spend all day on just this slide and I'd really like it. But as you admonished me before the surgery, we got to keep it moving before we start this talk. So, all right, we can keep it moving.
And then we have all our treatments on the other side, which we're going to talk about all of these except probably filtration surgery, but we're going to touch on everything else as we get into the cases. So we have 3 cases kind of lined up for you. We're going to start with case number 1. This was a 71-year-old patient that came to our clinic with some irritated eyes. You can see vision really good, 20/20 plus 1 in both eyes. We know the highest pressure, thankfully. It's always nice to have that, 29 and 28. That was before treatment. And then you can see the medications this patient's on, a prostaglandin, and then a fixed combination agent twice a day. So I say this patient's on 2 bottles, 3 medications. intraocular pressure 20 and 19, thin corneas, low corneal hysteresis, has had previous cataract surgery, and we'll show you some other imaging here as well. A couple of things I just wanted to comment on is, we utilize corneal hysteresis in our practice more as a risk factor assessment. And so when I see that 8, to me, that's a higher risk situation of possible progression. Anything above 10 would be considered a normal or high corneal hysteresis. 9 to 10 is kind of that gray zone. Below 9, I consider low, and low is the concern. And then, John, just a question for you. You see that Tmax pressure of 29, 28. You see IOP of 20 and 19. And not a fair question yet because you haven't seen the visual field in OCTs. But when we think about what we want from a reduction from Tmax, do you feel okay with where that pressure is right now?
Yeah, that's a almost 30% reduction. So what I want to know is this person now controlled or not controlled right now on their glaucoma? So that's high on my list. But of course, the thing that should be highest on our list is what's the patient coming for? And he's coming because his eyes are irritated.
Great point. And that's so important because in glaucoma, a lot of times we think about, boy, we got to prevent blindness. Boy, we got to prevent blindness. How do we do that? We add medications, or we do other things. So point well taken. He's here because his eyes are irritated, not for any other reason, and happens to be us to manage him. And this is what his corneas look like. So taking a look behind the slit lamp, they don't look happy. They don't look healthy. So we need to think about that as well. And then we'll give you the OCTs here, right OCT, left OCT here. Just briefly going through this, I think the concern more on the right side, you can see all that temporal thinning, superior, inferior thinning. I worry a little less about nasal thinning in glaucoma, but if it's more advanced, we start thinking about it. But that temporal thinning, very concerning in this patient in the right eye. And then in the left eye, even though it's green in that temporal quadrant, it's still borderline in that situation as well when we look at that. Per your question, John, sometimes we have this situation where we don't know if it's getting worse. We're going to have to make a decision on our own because we don't have old records. This is a new patient to us. We were unable to obtain those things. And so we're having to make a decision based off of what we have in front of us right now.
Yeah, so patient of ours, and I don't know a lot of the details of this, so it'll kind of be fun to see if what I say we should do is what we did together before. I want to think I did the old surgery because he was 20/20 +1, but the reason I know I didn't do the old surgery is because he didn't have a MIGS device, unless it wasn't done in the last 10 years or so. And that would put him at 61, so pretty young cataract. I wish this guy would have had a MIGS device when he had his original surgery, because his ocular surface might not look like that. And maybe even would have got a more impressive response than the 8 to 9 that he got from his drops.
Correct. Agree. And then quickly, the visual field, right eye, concerning that paracentral defect. That does match fairly well with the structure that we looked at when we think of the OCT. The left visual field looking pretty good. And so with that painted in front of you, John, and he's so accurate to everyone listening. I didn't give him much leadway on this. He didn't really get to see the slides, at least these slides, the cases. I was going to kind of put him on the spot to make it a little more interesting. And keep in mind, all these patients are our patients. So we designed the way that we treated these patients. So I'm going to throw it at you. What would you do for this patient?
Yeah, so a couple of things that I'm thinking. One, that visual field isn't terrible on the right, but it's central. And so I don't want to mess around with that too much. He's got great vision. If he loses some central vision, it goes from 20 plus down a little bit. So we don't know if he's getting worse. I'm gonna assume stability because he had about a 30% reduction, but he's got bad ocular surface disease. That's why he's there. So we need to try and take off some medications or add additional medications to try and treat his ocular surface. So you could add some dry eye treatments, but the best way to do addition is by subtraction. If you can make a person's life better by taking something away, let's do that. So to me, I'd be thinking a standalone MIGS procedure. I'd be thinking SLT, assuming he hasn't had one. I didn't see that in the history. I'd be thinking potentially drug delivery or something like him. I'd much rather do that than add a dry eye regimen to add more stuff to what he's already doing. So what would I do if my fellow came and told me what I just said? I'd say, okay, great, let's do that. And I just said a bunch of different things. So if it was me and it was my eye, I would do SLT.
See, I love the mindset, that interventional mindset, because this patient, for example, he could care less about that tiny paracentral defect. We care about that. He doesn't even know it's there, or that nasal step. What he cares about is the irritated eyes. And I think if we add more medication and don't figure out a way to subtract, he's not going to be happy. And so that's that interventional mindset. How do we reduce the medication burden? We did do SLT. We did pair it, though, with some drug delivery as well. So we attacked it a little bit in two different ways. Being that he was on multiple medications, we did a bimatoprost SR, which is a drug delivery device, which we're going to talk about here in a few minutes. Plus, we did selective laser trabecularplasty with the goal of giving this patient a drop holiday, giving him a break from his medications. You could see at 6 weeks, pressure down a little bit. Really not saying that, boy, bimatoprost SR and SLT is better than the 2 drops he's on, but the fact is, probably wasn't taking his drops appropriately because his eyes were bothering him. And so we see a nice pressure reduction. I was more interested in getting his eyes feeling better. He even stated that his eyes feel better. We're going to watch this patient fairly closely initially just to make sure that because of that central defect, he's not someone that's going to continue to progress on us. And recent visits, he's been doing really well off of all medications, stable visual field, stable OCT, and we'll continue to monitor him every 6 months going forward. So spot on what you said, John. We did SLT. We just added that little drug delivery device.
Yeah, and I think that, that makes sense if we're trying to get him off both medications, which would be really nice in this situation. So maybe SLT alone to get rid of 2 medications versus SLT plus a bimatoprost bump. Now, with high dose available, if that pressure starts to creep up after the bimatoprost wears out, then maybe it's an high dose move. And then the monitoring your patient every 4 months is important. And it's probably most important because you did that bimatoprost SR and you're not quite sure when that's going to start to lose effectiveness on a patient whose pressure was in the 30s previously.
So really quickly, the impact of multiple glaucoma medications, I'm probably preaching to the choir here, but we know as you increase medications, you get more dry eye disease, more issues with the surface of the eye. So it's not that medications are bad, it's stacking multiple medications on top of another that really can create the problems. And so, as John said earlier, minimizing the medication burden can really make an impact for a lot of our glaucoma patients. It may not be elimination, but at least reducing them or keeping patients on one or so. We also know that certain medications and a lot of medications can affect the ocular surface, the meibomian glands. There's studies showing 90% meibomian gland dysfunction in patients that are on PGAs, sometimes mild, sometimes moderate, sometimes severe. This study, which is interesting, goes to what I just said. The more medications a patient is on, the more likely they're to be more symptomatic, to have a worse tear breakup time, more corneal staining, and worse meibomian glands. And so what you're looking at here is group 1, they were on 1 medication. They were on a preserved medication or a preservative-free medication. Group 2 were on 2 medications. Group 3 were on 3 medications. And their scores in each one of those categories gets worse as there's more medications that are being utilized on the eye. So it goes back to what we mentioned a minute ago. If you can minimize it, likely you're going to make your patient's quality of life better and likely control their glaucoma better as well. Because if you look at this particular study, this looks at patients over time with side effects versus no side effects. And you're looking at visual field progression here. Patients with no side effects, did they progress? Yes. Glaucoma is a progressive disease. We would expect that. They're going to progress. But look at the patients with side effects, the difference, the gap that forms over time. These patients were still being treated, but they had side effects. Their visual field got progressively worse quicker because of the side effects. So how do we minimize that? That's that interventional mindset that we're going to touch on here as we go into some of these treatment options. So what can we do from a drop standpoint? We have a preservative-free latanoprost that's now on the market, recently introduced. Don't really want to get into a ton of data here, but just wanted to show you a phase 3 clinical trial in the US, a phase 3 clinical trial in Europe. And the main question that I typically get around preservative-free drugs, this one in particular, preservative-free latanoprost, is it as effective as the branded medication? And what these 2 studies have shown in a low baseline pressure situation in the US trial and a higher baseline pressure situation in the European trial is that, yeah, they're as effective, and you can feel confident if you want to switch your patient from a traditional prostaglandin because of irritation or non-tolerance, you could switch them to a preservative-free latanoprost and feel comfortable that you're going to get effective IOP lowering with it. We also
Just one thing I want to point out from that data just real quick.
Yeah, of course.
How much more response there is when the pressure is higher. And, anytime you've got episcleral venous pressure as the backstop, the lower the pressure is, the less effective the treatment will be. So it's not necessarily true of trabs and Zens and stuff that goes underneath the conjunctiva, but it is true for the vast majority of treatments we have.
Some other preservative-free considerations, a BAK-free latanoprost that's available. We also have some preservative-free compounded medications as well that you see over there, where you can do a single agent, you can do some combination agents and some triple combination agents as well. None of these usually my go-to first line, but always in my back pocket for a patient that's not tolerating my traditional prostaglandin agents, or someone that we need to add adjunct therapy to, that I'm worried about ocular surface disease. You should have these in your back pocket to at least consider for those types of patients.
Do you think we underutilize those?
I think we do at times. Yeah. I mean, we use a fair amount of the compounded preservative free, but I could probably utilize more in my patients that are suffering from ocular surface disease. But I think drug delivery has changed my mindset a little bit. It's much easier for us now to go to drug delivery.
Yeah, because it's not just the preservative that can cause the toxicity. The drug itself can cause the toxicity too. So you eliminate that entirely. And I just saw, as you advance that slide, that underutilization, like I said, for these is probably a much bigger issue with the next technology we're going to talk about.
Yeah, which is SLT. And a lot of you are familiar with SLT. You're familiar with the LIGHT trial. They just released some 6-year results of this. And this was a study that compared drops versus SLT, robust study, 370 eyes per group in it. And I think the take home for me, John, is right at the bottom here. 70% of patients in the SLT group drop free at 6 years. And probably the fact that less aggressive surgery was needed. You can see trabs required in 32 eyes in the drop group, only 13 MSLT group.
Yeah, I mean, it's clear. It's just absolutely clear that SLT should be the first line therapy. And it's fascinating to me. At our optometric symposium every year, we ask the same question. How many of you think that you'd want SLT on your eye first line? Everybody almost raises their hand. How many of you have the majority of your patients do SLT as their first line therapy? Nobody raises their hand. And maybe sometimes even not us. And so there's this hidden barrier to getting us to do what we already believe is right. And it's up to us to get ourselves over that hump.
I want to ask you about this, John, real quick. This is a paper that's already out. So if you're interested, this is published. This is the rationale for a COAST trial, which is an ongoing clinical trial occurring in the US right now. A brief overview. They looked at newly diagnosed primary open-angle glaucoma patients. What they were looking at is if they did low energy SLT, like 0.4 millijoules, that's the number 3 spot here. They did it annually, regardless of what was going on with their disease process. If it was controlled, they were getting low energy SLT. When you look at this data, medication-free rates, low energy SLT outperforming ALT standard SLT, and the need to treat again, low energy SLT outperforming. Do you foresee this being something where a patient comes in for a visual field and OCT and they're going to get their annual SLT, or do we need to wait for the COAST trial to kind of come out and give us that information?
I think that until the COAST trial comes out, we would use it in those patients that really are drop averse, perhaps, and maybe even more importantly, pharma averse, because there's a set of patients that know that they just don't want any drugs in their body at all if they can help it. And so I think that for now, it's not a standard approach, but a more niche approach. But if the COAST trial comes out and is clear that this is the way to do it, I think it's fascinating. And I do wonder about, the repeat inflammation cycle that's just helping remodel the trabecular meshwork and have it continue to function. It's like brushing your teeth, once a year.
Sorry. Yeah, I'm just impressed. This is 10-year data here, and it wasn't, hey, a year or 2 years,
Yeah.
5 years. It's extended
Yeah.
data. So I'm anxiously awaiting the Coast trial as well. Glaucoma drug delivery, an exciting arena in glaucoma care. It's probably one of the most exciting areas for me personally. I enjoy treating patients with these technologies we're going to be talking about next. Bimatoprost SR, this is a biodegradable bimatoprost implant. We'll show you a video of it here in a second. It's approved to lower intraocular pressure in primary open-angle glaucoma and ocular hypertension. It is a single intracameral administration. So by the letter of the law, you're only supposed to do one of these. I don't want to get too deep into that because I know John and I, we've discussed this before, and he doesn't like rules around these types of things. If it's best for the patient, then we should do it again. But indication is you only should do one of these at this point in time. It is biodegradable. So once it's inside the eye, it will dissolve over time. It's one drop of matoprost in that pellet. So drug delivery, that's the uniqueness of it, preservative-free, small amount of medication inside the eye. John, I'll have you take us through this video here and how this is done at the slit lamp.
Yeah, so this was done during COVID, as you can tell. And so you can do it at the slit lamp with a numbing drop. Make sure that the patient's in good position. You are using kind of 4 of your 5 fingers at once, maybe even all 5, because you're using a couple of fingers to hold the eyelids open so they're not going to blink. But if they're numbed up, it's surprising how little blink that they want to do. So you can see it here is pretty standard. This needle is particularly good because it's a TSK needle that's really sharp and really thin, so it penetrates the cornea well. You can see that little pellet was inserted, and it kind of goes like a snow globe down to the bottom of the anterior chamber and sits down there. Really straightforward procedure to do. And Justin, I'll tell you, we talked about this when it first came out, and I just didn't think we were going to use it much. Labeled for 4 months, no repeat administration, at least on label anyway. And I just didn't think that was going to be as big of a benefit. And this is one of many times where you were right and I was wrong. We do a fair amount of it, and patients really do appreciate that break from their medications. And now with longer term therapies available, I think it's going to be even more drug delivery is going to be even more utilized.
And it doesn't change the way we manage our patients. So, like when John inserts one of these, I usually will then see the patient back 4 to 6 weeks later for an IOP check, which I would do if I started a topical medication. So we don't change technically the way we manage them. And then I will follow up with them periodically to see what's going on with their intraocular pressure. And, you mentioned it. Sometimes we'll get 6 months of IOP lowering with it. We've seen a year out of it. The data is even showing you can maybe get 2 years out of it. You just have to watch the patient. We don't necessarily know how long. Confident you'll get 6. And now there's some long-term data coming out. This was just some real-world retrospective data on this, showing bimatoprost implant IOP lowering in a lower baseline pressure situation. These patients had about a baseline pressure of 17. They followed them for about 13 months. You can see that intervention with SLT started to occur, around 3 to 6 months, and about 18 patients needed it at a year. But on the far side, you see a good reduction in medication as well. And so again, not a long-term therapy, but glaucoma is a marathon, and we're going to intervene with a variety of different agents as well. And then we have this technology that just came onto the market, a travoprost intraocular implant, that when you see the data here in a minute, there's data showing that it may last out to 3 years to get us IOP lowering. This is more of a surgical procedure, and I'll have you take us to the video on this as well in a second here, John. But this resides in the anterior chamber angle, anchored behind the trabecular meshwork, releasing travoprost. This would be your view with gonioscopy. This is how you would see it behind the slit lamp. And then this is the surgical procedure.
Yeah, so this is a case of ours. And so basically you make a small incision, go across the eye, visualize the trabecular meshwork, make sure you're actually pinning this little dart right into the trabecular meshwork, and then that little anchor goes in the scleral wall. You release the 2 prongs on each side. You kind of nudge it on each side to make sure that it's anchored securely. And that's the procedure. Now I can make it look harder than that, and I have made it look harder than that, but that was one that was fit for showing. We were in the clinical trials for this. We were in the clinical trials for the Durista. It just is really great that companies are advancing the science and bringing these technologies forward to help our patients. And the data from this has been really astoundingly good.
All right, we're going to jump to case 2 now. Case 1 kind of got us warmed up. So this was a 65-year-old patient. That interesting story around this, one of our colleagues, friends in the community, actually told the patient, hey, you have glaucoma. And the patient said, I don't have glaucoma. I don't have high eye pressures. There's no way I have glaucoma. Our colleague, our friend in the community said, you do? I'd like to start treatment. They said, I want a second opinion. They called us. I said, of course, buddy, we're happy to see the patient. Send them in. We had the records on this to, confirm it. We'll show you that. And we'll see what you all think. So that's kind of the background on this particular patient. So it was the second opinion for possible glaucoma. No high eye pressure ever documented in her chart. You could see in our office, it'll be on the next slide, but her max was 17. So 17 was the highest pressure that this patient had. Has had cataract surgery, had a YAG capsulotomy, has a family history of glaucoma, not on any treatment when they came into our clinic. And then you can see some of the other medical history as well.
So, Justin, one thing, you can kind of tell where this is going since it's a glaucoma talk and she's never had high eye pressures. Normal tension glaucoma is not rare. In the United States, it's at least 30% of the glaucoma that we have. Hispanic, maybe around 50%. Japan and East Asia, 85 to 90% of open-angle glaucoma is normal tension glaucoma. So a couple of things. One, lowering the eye pressure still matters. It's critical to lower the eye pressure. It's a very difficult disease to treat because our current therapies don't work as well. And there's a bunch of balloons going off on my screen there. It is my Zoom is very excited about normal tension glaucoma. And we have to watch these patients, really carefully. And we're missing a big picture of why do these patients get worse? Why is normal tension glaucoma even an entity? I've got a lot of thoughts on that, but we can maybe save that for another time.
We won't have time for all your thoughts on that, but I do like all your thoughts on it. But we'll have to make sure we don't allow you to have all those thoughts, or we won't get anyone on here tonight.
Sounds good.
Uncorrected visual acuity for this patient, 20/20 in the right eye, 20/20 in the left eye. You could see a really slit lamp exam, everything looked normal, no transillumination defects, no exfoliated material. I always need to be looking for those things in these patients. Well-centered IOL. Pressure in our office that day, 16 and 17. Corneal thickness on the thin side, 499 and 504. Concerning gonioscopy, we need to do it, but everything looked very normal in order to diagnose. And then corneal hysteresis, kind of in that gray area, 9.4 and 9.3. Here's the nerve appearance. Just wanted to show you the asymmetry here between the right and the left, a 0.7 roughly on the right, 0.5 on the left. So some asymmetry between the two eyes. OCT here. Again, you can see in the right eye, fairly significant temporal retinal nerve fiber layer thinning. And if you can see my pointer here, I'm a little worried too about this kind of ganglion cell defect here also in this right eye. The left eye, kind of mushy, not sure if there's really any ganglion cell problems here. Not a great image. But again, we have some early temporal thinning that's showing up on the Tisnet curve and on our segmentation plot. So again, red flags to me right away. Now we need to see the visual field. And you look at the right eye. To me, again, that matches structure and function. The beauty we have for this patient is our colleague, another optometrist in the community, had already done a visual field. These visual fields matched very, very closely to one another. So the right eye, although slightly different on his scan, almost identical, paracentral defect, this nasal step, very concerning, where the left eye could argue there's an early nasal step there, but overall pretty clean, matches kind of what we're seeing on our OCT. So this was my diagnosis, moderate normal tension glaucoma in the right eye. Depending on the system or grading scales you use, you could argue that's severe with the central area that's involved. Preparametric normal tension glaucoma or mild normal tension in the left eye, because you don't have to have a visual field defect to necessarily diagnose glaucoma. And so once again, with these diagnoses, and if you disagree with me, John, please jump in, but I'm going to put you back on the spot. What would you do for this patient? What would be your treatment? And I can review anything. If you have any questions, I can come back to those. But remember, no cataract surgery, has not been treated yet. Tmax pressure of 17. If you agree with me that there's glaucoma there, probably need to manage or treat this patient. What would you suggest?
Yeah, and how old is she? 65?
65. 65.
Yeah, okay. So, she's probably, I bet she's fit. I bet she's slender. Her blood pressure wasn't terribly low, but I wonder if her blood pressure goes down at night. One of the questions I like to ask them is if they've ever had, spinal surgery or even an epidural when they had babies. Normal tension glaucoma, much more common in women. Where I'm going with the spinal surgery stuff is if they could have a reason, an iatrogenic reason for having a low cerebral spinal fluid pressure. But I'm worried about this patient, man. I don't have great tools for this patient. Her pressure is 16 and 17. I think she probably needs to be on an eye drop. And not probably, I'd put her on an eye drop, but I'm concerned we're not going to get much benefit from that because, as we already talked about, getting an eye drop from 17 down to 14, 13 is maybe the best that we're going to do. And then you start adding additional eye drops with diminishing effect. Now you're torching the ocular surface. So then you start to think about, intraocular drug delivery. Okay, that's fine, but it's still going to not have a great job of lowering the pressure. And so then I start to think, all right, maybe a goniotomy plus ECP or something like that, but you're still subject to episcleral venous pressure. So you all of a sudden you feel like you're on the way to something subconjunctival. And so, for me, that would probably be the first thing would be a Zen after trying some medications. I usually do MIGS prior to going to Zen. So first step, prostaglandin, kind of spitting in the wind, maybe add a second medication, then go to probably a MIGS that I'm not sure that's going to work so that I can feel like I tried everything before I go to a subconjunctival procedure. So that's what I'm thinking. What did I actually do? What did we actually do?
It's amazing we think alike. I wonder why that would be, that we would think
no kidding.
much alike.
Chamber.
We did. We started with a prostaglandin. So we went with one, that has some data around low tension or low baseline pressure glaucoma. The Jupiter trial is what I'm referring to with latanoprostene Bunad. And we started there and we did get a good response. But I love what you did there is, okay, we got a great response, but you're thinking way ahead. And I think that's so important in glaucoma is, all right, so I know what I'm going to do initially. And if we get the response we need, great. But what happens in a year or 2 years or 3 years when in a tough scenario like this patient is in, and we're very likely this drop, yes, it'll work for a while, but is it going to work forever? Probably not. What do we do next? And I do that all the time. I document that. We put that in our chart. Hey, this is number one, what we're going to do, number two, number three. And so that's always in there. So I love the way that you laid that out on how you would manage this patient. But this is what we started with, which is a topical medication.
That's an impressive response. I would say atypically impressive. You agree, Justin?
Agree. Yeah. And that's why I love the way you laid it out, saying we're going to try it. If we get this response, great. A lot of times we don't get this response, then we got to have our next step. And you said,
here's a parallel psychological piece to that is if, let's say we try drops that we don't think are going to work. Then we try MIGS, which we probably don't think is going to work that great in this patient. Now we're going into a surgery that has a lot of risk after doing two things that doesn't work, and the patient may have lost some faith in us unless we lay that out first. Because I don't want to go into a subconjunctival surgery because even if it goes perfectly in the OR, it can end up in a bad spot.
Educate beforehand, way beforehand. They've heard it before. You're gaining their trust. Great advice. So I'm going to cruise through this real quickly because I want to get to kind of talking about, what do we do with normal tension glaucoma? What are our considerations? I think it's one of the more artful glaucomas we have to treat because of the fact that it is intraocular pressure related. We need to lower it, but there's so much more at stake. And there's so many other things that are intertwined with it. And you mentioned a lot of these, blood pressure, which is kind of connected with ocular perfusion pressure. We're going to touch on CSF pressure as well. But all these different things in the literature have been shown to be at least connected to normal tension glaucoma. A study that I really like and have read is this particular one. interesting when you look at the right side here. They looked at these patients that were considered over dippers, non-dippers, physiological dippers. And what they were looking at was when patients went to sleep at night, what happened to their nocturnal blood pressure. And to make this very brief, the patients that had big drops over 20% in their nocturnal blood pressure compared to their daytime pressure progressed much more rapidly on the visual field. And these patients were all normal tensive glaucoma patients. Non-dippers, physiological dippers, not as much, but those over dippers, greater than a 20% reduction in reduction of blood pressure from daytime to nighttime, progressed much more rapidly. So something that we at least want to think about and consider if your patient does have really, really low blood pressure when they come in and you're managing them.
This is where you start to be kind of like a real doctor, where you're trying to think about more than just what's going on in the eye here, but what's going on with their whole physiology, their blood pressure, their systemic medications.
I want to give you about 30 seconds to take us through a study you did here with CSF pressure, intracranial pressure, because this is kind of your baby here.
Yeah, sure. So this will probably be the most important contribution I make to our profession, which is that glaucoma probably is a balance between intraocular pressure and intracranial pressure. So high IOP or low CSF pressure. And we looked at 50,000 lumbar punctures, found patients that had glaucoma, that had had previous lumbar punctures. And what we found is that people that had normal tension glaucoma had the lowest CSF pressure. Ocular hypertensives that had high eye pressure but didn't get glaucoma, they had an elevated CSF that was protective. So what I'm really saying is it's the pressure differential across the optic nerve on IOP that's higher than CSF that causes the optic nerve to bow backwards, stop axonal transport or slow it, and the ganglion cells die. We know CSF pressure affects the optic nerve because we see it in papilledema, pseudotumor cerebri, where the CSF pressure is higher than the IOP and the optic nerve bows forward, but we also see it in hypotony, where the IOP is too low, CSF is higher, and the optic nerve swells and moves forward. I don't know if I did it in 30 seconds. Ours was retrospective. Rujan Ren and Ningli Wang and his team did this prospectively, which is a much better design to do a study like this. And he found an even more pronounced stepping of what CSF pressure does. Ocular hypertensives, high CSF pressure and protective, glaucoma, lower CSF pressure, and a really low normal tension glaucoma. And as you start to see glaucoma through this lens, it starts to make a lot of sense, and it explains normal tension glaucoma and why some people that have a pressure of 28 don't get the disease.
I have no idea how Dr. Ren got patients to sign up for a prospective study and do lumbar punctures on them, but that's impressive.
Dude, so interestingly, Mayo Clinic has a study on natural aging, and they do lumbar punctures on patients every year as part of a natural aging study, not just to study a disease. So just like we're scared to put a needle in the spinal column, but we'll do incisions in the eye all the time, they're scared of the opposite.
I'll pass on that for me being enrolled. So question for you. So what works when our patients are most vulnerable to glaucoma? And when are they most vulnerable to glaucoma, John?
Yeah, we don't have, honestly, Justin, currently we don't have great answers. Subconjunctival surgery is the best that we've got right now for these really tough to treat patients. And you could kind of see me sigh there because I don't want to subject a patient to these surgeries if we don't have to. They're better than the alternative, which is not doing anything and slowly going blind for sure, but they come at significant risk. And anybody that does these surgeries has lost eyeballs because of these surgeries. So there's not great answers. There's answers. Hopefully on the horizon, we'll have some new technologies.
And when I think of vulnerability to our patients, it is at night with these patients, right? We know that our patients are their intraocular pressure is rising at night. We have some medications that work at night, some that are terrible working at night. Our beta blockers, alpha agonists, not good medications for normal tension glaucoma because they don't work at night. But there is technology on the horizon, and we're going to introduce one of those technologies next that obviously you're very close to. The next 3 slides, can you just take us through this particular device that is not quite yet in the hands of any eye care provider, but could be in the near future?
Yeah, we're hopeful. So this is the Physics, that's how you pronounce FYSX, Physics Ocular Pressure Adjusting Pump. Basically what it is, and we developed this, and Justin's been intimately involved with us along the way. We, on March 21st, we had an FDA panel, which is a very rigorous process that's all online and available. So this is all publicly available information, where we present to the FDA and to the panel of 13 experts on whether or not this device lowers intraocular pressure and if the benefits outweigh the risks. And that was a unanimous recommendation that the benefits did outweigh the risks. And so that we're hopeful of an FDA approval in the not too distant future. But here's what it is. It's a pump over on the side, individually goes to each goggle. That lowers the pressure, the atmospheric pressure in each goggle. So we're pressurized by all the weight of the atmosphere. By releasing some of the weight over the eye pressure has to go down. So imagine if I pushed on your eyeball, your eye pressure would have to go up. No choice, just physics. If I take my thumb off your eyeball, your eye pressure has to go down. No choice, just physics. And that's what this does. Now, it only works while you're wearing it. And so we anticipate that would be at night while you're sleeping. When your eye pressure goes up, we lower that pressure and help keep it in a better therapeutic range. And hopefully, ultimately, that helps slow the progression of glaucoma. The data is pretty robust. It showed we had 2 multi-center randomized clinical trials. One is the Apollo study that was in open-angle glaucoma patients. This one was the Artemis study in normal tension glaucoma patients. Keep in mind when you look at studies in open-angle glaucoma, we have a lot of things that do a good job of lowering eye pressure from 25 to 16. We don't have a lot of things that do a good job of lowering it from 19 to 12, especially on top of additional medications. So both of these studies were designed to not wash out medications, leave the medications on, and then apply the therapy and see how much additional IOP lowering you got in addition to therapy. And so if you look at the Apollo study over on the left, the open angle glaucoma study, we went from 19.4 to 12.9. That's a 34% reduction. But even more impressively, I think, in the Artemis study, and by the way, we did this in sleep labs during COVID. We'd have patients wearing the goggles at night, measure the pressure in the sleep labs. 100% of eyes had at least some IOP reduction. I actually think, Justin, it's 97% of eyes had a greater than 20% reduction at night when they were sleeping. So that's almost everybody got a 20% IOP response. You're not going inside the eye. You don't have the pharmaceutical side effects. What you do have, though, is you do have some puffiness underneath the eyelids. So I am hopeful that this will give us another tool, should it get FDA approved, to help take care of some of these really difficult to treat glaucoma patients.
Yeah, what excites me about it, as an optometrist and what, my colleagues on here listening to us is it's an opportunity for optometrists very likely to get into, the device space of glaucoma, glaucoma devices, which it's its own category. It'll be brand new. And so that's an exciting thing. We're used to fitting things around people's eyes, spectacle lenses. And so that's a beautiful opportunity for us to get involved in devices. So I'm looking forward to this.
It's really an entire category of care. It's the first time we have something that's non-drug, non-surgery to do to lower IOP.
So we have about 9-10 minutes left, and we want to leave a little bit for questions, John. So we're going to go fairly rapid fire through case number 3 here when we talk about what we're going to do with this patient. So this was a new glaucoma evaluation. The patient had previous cataract surgery, really was having troubles handling their medication. Actually, if you look at the image there while that's on there, is they have rheumatoid arthritis. And so putting drops in their eyes, not easy. You can see the surface of their eye. Not good either, similar to our first case there. Prostaglandin.
One, rheumatoid arthritis patients have more dryness, and she's on, 3 medications. So
yeah, tough. Prostaglandin, your balloons came back again.
They love bad glaucoma balloon.
Prostaglandin once a day, fixed combo agent twice a day. So again, 3 medications, 2 bottles. You can see the pack. You can see the cup to disc ratio. Mild pigment in the trabecular meshwork. Tmax 26-25. Current pressure 17 and 18. And here's the concern. We look at July of 2021 to July of 2022 to July of 2023. There's this progressive thinning in the temporal quadrant. Temporal superior gets involved. The average RNFL keeps going down. And so temporal thinning is concerning to me. And then you look at the visual field as well. The pattern standard deviation, kind of listed those on the one side there, increasing, an indicator that, boy, we have progression on the visual field as well. So we have a central defect. We have progression on the OCT, progression on the visual field. We have a pretty good intraocular pressure, John, at 17 and 18 right now. And so now, what do you do with a patient like this? Lower baseline pressure progressing on, you would believe that's where the pressure is. What's our options here?
Yeah, with what's currently FDA approved, so the physics wouldn't necessarily it could apply here, but it's not approved. Should it get approved, that might be something to consider. I'm doing a Zen. This patient is on. Well, let me take that back. Her pressure is 17. I'm probably doing a goniotomy and ECP with limited expectations, but glad that it's going to be safe. So I'm probably doing a goniotomy ECP, and not surprised if I move on to a Zen. The other thing that maybe informs me about that a little bit is that with a Zen, I'm going to really need them to do a good job taking some of their post-operative medications, and she probably has a hard time to do that with her arthritis the way that it is. So I'm probably starting there.
Yeah, I think angle-based procedure, a very good option for this patient. We did an angle-based procedure, just a little different angle-based procedure. We actually did a 3-stent system that's now available. We'll talk about that here in a minute. Angle-based, we're placing 3 stents. This patient had no stents, no angle-based procedures before, just cataract surgery. And we didn't get a ton of IOP lowering. You could see we got 15 and 14. We're going to watch this patient really closely because if they continue to progress and their pressure's there, I do agree with you. We're probably moving down the line of either doing another angle-based procedure like a goniotomy, or we're probably moving to a subconjunctival device.
Yeah, I'm kind of surprised that I didn't combine this with ECP, because I usually think that I get another millimeter of mercury or 2 with an ECP. And if we would have went from 17 to 13, I'd feel pretty good. 17 to 15, I feel like maybe I can hope that it's lowering pressure at night a little bit, or at least evening out some things. So I wouldn't say a failure, certainly safe, but I'm a little surprised I didn't add ECP.
Yeah. It was probably your partner OD that didn't add it, so you can blame
probably
it on
IBOC. It was probably his case. That bozo.
So real quickly, rapid fire, John, stents, iStent inject W, Hydrus, these 2 procedures, where do you utilize these?
Yeah, so I do like stenting, and I use considerably more iStents than I do Hydrus. I think that it's a little more straightforward procedure. The data is awfully good for the iStent and Infinite, when you're putting 3 devices in. So I think that we're using it in mild to moderate glaucoma. If it's with cataract surgery, if it's standalone, it's a refractory indication, which usually means that they've had maximum medical therapy or a prior surgery like ECP, or even prior filtering surgery. And it can work in patients that have had prior filtering surgery.
So with these devices, just reiterating what John said, done in combination with cataract surgery, mild to moderate glaucoma, that's kind of the indication around these. Low-hanging fruit, those are your patients that you want to recommend that to, that are on medications. This is the one, as you mentioned, refractory glaucoma. It's what we did in the last one. You can stent in a standalone state. These patients have to have failed with medication, or they've had to fail with a surgery to be able to do this particular device. 3 stents placed about 3 clock hours apart. What about your goniotomies? Where do you implement these? And you've mentioned multiple times, you a lot of times pair these with endocyclophotocoagulation, which is decreasing aqueous production, cilioblating the ciliary processes. Where do you pair these typically in your treatment algorithm?
Historically, it's been standalone, because you were able to do it in standalone without, going off label and without, and you know, some of these things don't even really have a label because they're a tool that are used to, you know, do a goniotomy. And that gave us a bit more freedom. Now that we've got some good data around standalone approaches, it's a more mixed bag. And almost all the time, if I'm going in with a standalone approach, I'm going to add ECP just because we're going in the eye. I want to get as much as I possibly can. But if you are using ECP or your surgeon's using ECP, intraocular steroids is almost a must because the real bang against ECP is too much inflammation. Now that we've got good access to intraocular steroids, I think that it can work well. So this is going to be the patient that's not tolerating their medication very well, or they're progressing and their pressure's 20 or something like that, and we're going to go inside the eye and make them worse.
Similar standalone procedure, really in the categories of the goniotomies. The difference here is small catheter that as they're retracting it, they're injecting viscoelastic to kind of open up that canal. And then the final part of the procedure is they're actually able to strip or remove the trabecular meshwork. So kind of a combination of that kind of goniotomy, trabeculotomy plus canaloplasty that's occurring. Standalone patient, again, typically not done in combination with cataract surgery, can be, but not typically. And then that subconjunctival stent that John had mentioned, you know, multiple times. This is for more advanced glaucoma. We've moved away from those mild to moderate patients. This is our more severe patients. You're going to have to be comfortable with managing a bleb. As you can tell here, you get a little bleb formation. You get 1 to 2 millimeters of it in the anterior chamber, 2 to 3 in this intrascleral space, and then that subconjunctival bleb that forms here. An effective procedure, but reserved more for advanced glaucoma because you can get hypotony with this, bypassing episclerovenous pressure, and you have to be comfortable with managing those types of blebs. This is one of our colleagues doing an ab interno Zen procedure. John, you could take us through it quick if you don't mind.
Yeah, sure. Quick paracentesis, little inside the eye, intracameral lidocaine. Sometimes we soak the conjunctiva, make an incision, use the Vera hook to hold it in position, go across the eye, find where you're going to target this. You make this pass, and you're going to see the needle kind of pop out underneath the conjunctiva. It's going to look like it almost is going through the conjunctiva. You want it to really try and get above tenons if you're taking a ab interno approach. A lot of people are taking an ab externo approach now. We kind of have a preference for putting it infranasally, which I don't know that anybody else in the country is doing, but then we leave the superior conjunctiva for future surgery if we need it. Here's some mitomycin C and a little bit of bleb needling there on the table to make sure that you're trying to get tenons out of the tube. And then we push the fluid into the mitomycin C into the sulcus to try and get that bleb to go more posteriorly.
And I'm going to take about 45 seconds to just go over the post-operative considerations of MIGS. Really have 5 big ones here. Stopping glaucoma medications. You know, we don't have a cookbook recipe for this, but my suggestion typically is with MIGS procedures, anything but Zen. I usually like to leave them on their medications for about 1 month, get past that point where there could be a steroid spike, steroid change. And then around that one month mark, I'll consider, if I'm at target pressure, peeling medications off over time. If the pressure goes back up, we can always add it back. But my recommendation is usually wait around a month before you start peeling medications. IOP spikes, you're going to get it. It's glaucoma. Pressure is going to happen. What can you do in these scenarios? You can throw oral medications like Diamox on them. You can do topical agents. You can burp a wound if you're comfortable doing that as well. Hyphema, educate on the front end with hyphema. With hyphema, I tell patients with any MIGS procedure we do, you're probably going to have a week where your vision's a bit cloudy. That's because a little bit of blood may get inside the eye. Better to have them prepared on the front end than on the back end. And almost nothing needs to be done for hyphemas. It's just a wait and watch approach. About a week, they're going to clear up, get better, unless it's a full-blown 8-ball hyphema, which is very uncommon, can happen, but very uncommon. If that does, that goes back to the surgeon. Hypotony, you're only going to see it with a Zen stent. Make sure the anterior chamber is formed. Check the back of the eye for any choroidals. If those 2 things are there, it's a wait and watch approach, but get them off of all their medications. You won't run into hypotony with the goniotomies, with the other stents, because you're not bypassing episclerovenous pressure. And finally, just establish new baselines. After these surgeries, you're going to want to follow these patients going forward, and keep the glaucoma puzzle in your mind as you're managing your patients tomorrow in clinic.